Good morning, everybody. The topic of this lecture will be the rotational and the three-dimensional angiography. And you heard yesterday during the lunch symposium many information about that. And yeah, thank you. But I try to reduce the redundancy to a minimum. Okay, here we are. So if you think about the conventional angiography, and it's always combined with the question how to get an optimal projection of that what you want to see. So normally you perform an angiogram in a standard projection, and then you perform a second angiogram in a probably better projection, and probably you need a third angiogram only to recognize that the standard projection was not good, but perhaps the best of those three. And to avoid this means that you are always get connected or in touch with the question, can we get informations of different projections performing just one angiogram? And that is the basic for the need and the use of the rotational angiography. And the other question is, can we get more spatial information by computer-assisted analysis? And that is the basic for the technical approach for 3D modeling or for the mapping with image fusions, what already you have performed prior to the angio, which means a CT, the three-dimensional echo, or a MRI study in any way. So I want to focus on 4 topics. The first is the rotational angiography, the second is the 3D modeling, and with a very short touch of the advanced rotational angiography, and then at the very end, the mapping, what we have seen yesterday during the lunch symposium. So if you start to think about a rotational angiography, then you can have 2 approaches. The first is either you rotate the patient, which is not really useful during the recording of the images. So you have to rotate your imaging equipment during the angiography. So in this situation, it's very helpful if you have the free selection of the degree of the rotation, and the rotational speed of the machine should be good enough and fast enough to allow short acquisition times. If you want to attribute this in combination with different viewing angles in each angiographic picture, that means that you need a 3-dimensional reconstruction of that what you have recorded. Either you can do it manually with a computer or semi-automated, or in the meantime there are automatic contour analysis softwares which are going to help you in this very much. The software which can rebuild a 3-dimensional model out of 2 contours from different angles, that is something what would be the best if you just need a biplane machine with information of that, and you do just one angio, short shot, and you can reconstruct from these 2 angles a 3-dimensional model. That will be the future, but it's not available yet. So if you look here, it is a coordination of the investigator and the person who starts the injection of the contrast medium. So you have to start the contrast medium injection just a second before, half a second before you start the rotational machine, and then you can achieve these kind of a rotational angiography, which gives you really help to rule out what is the best projection to give you the information you need for any decision making. One point and one aspect is very important. You should dilute your dye, which is normally maximum 1:1, soluted with 0.9% saline solution. The duration of the normal 3-dimensional rotational angiogram is roughly 4 seconds. That means you need to calculate the dye application for 5 seconds in total. And that's what I mentioned. It's very important that you coordinate with your colleague, and you have to start the dye application roughly half a second prior to start the angiography. The dye flow is, with regard to the body weight, different, and should get speed up to 15 to 20 cc per second if it is more or less an adult size patient. Here are some examples. This is a very large PDA in an infant. for interventional closure, and sometimes it's very hard to have the best projection for measurement of this PDA. And there is a rotational angiography very helpful. And this is a coarctation in an adult with an aneurysm formation. And also to start and to plan your procedure, what you want to do, sometimes it's very helpful to have the best orientation, the best angle for guiding your intervention with this regard. This is another very complex patient. Here you see a residual mild residual coarctation combined with a very large aneurysm, which is starting here. And what we know from the MRI study prior to the procedure, this is the aneurysm, this is the coarctation. It's a 44-year-old female. And that is the rotational angiography to see what is really the fact with the aneurysm. And with this regard, we planned to fill the aneurysm with an occluder and had the measurement of the entrance to the aneurysm, which we implanted a 12mm VSD occlusion device from the HA company within the aneurysm to close the entrance to the aneurysm, and then we put a covered stent via this region to have a treatment of the coarctation in this situation. So what's about 3D modeling? So if you want to have spatial information about that, what you want to have, this is a rotational angiography in an ICAPA. And you can reconstruct that very easily, and you will have a three-dimensional information about your coronary artery system, which is not necessarily important in this situation, but it gives you, in other examples, a very nice information about that. This is a standard coarctation, and prior to the procedure, it is important to rule out what is, the problem of the hemodynamic importance of that region, and you can rule out the best angle, and you have the opportunity to detect for measurements for a renewed implantation of a second stent or another procedure, whereas the minimal foreshortening for measurements that you need, especially if you wanted to measure the length of the region, what you want to cover with your second stent implantation. And in this regard, you can rule out which is indicated with the green zone here in your 3D modeling. In this, if your projection or your angle of your machine is within this green zone, you can make sure that the foreshortening of your measurements is minimal, if not zero. So that is very helpful in this regard. Here is another example for a complex pulmonary valve implantation with regard to the origin of the coronary, with regard to the implanted PA stent. And here you can see what is necessary to do, and this is the entrance to the coronary artery. And you can also watch to this during the inflation of the balloon, which is an atlas balloon here, inflated during the angiography to see whether this will impinge or will impair the flow of the coronary artery during the inflation, which is in a short second reconstructed automatically. This is another spatial information of an aneurysm, another patient with an aneurysm after core repair, surgical core repair, to plan and to measure which kind of the stent, how long the stent should be, and where you have to start with the stent implantation in any way. So this is the same patient where we started to implant a first covered stent, and the covered stent you can see here was not sufficient enough because you have residual flow into the aneurysm, as you can see here in both projections, and you see that also in the rotational angiography here, which gives you all the spatial information what is necessary to deal with the patient. And after implantation of a second covered stent here, you could demonstrate that you have a full closure of the leakages of this aneurysm. So what about the advanced rotational angiography? That is something what is a bit complicated. If you look at your diagram, you have cranial and caudal, you have RAO and LAO projections, and you know that in the caudal position is the minimal foreshortening, and you know that in the cranial RAO position is minimal foreshortening. But as well, you have a LAO caudal projection with also a minimal foreshortening, and that means that you probably need a swing for your rotational angiography to have the best insight. And this swing, it can be automatically programmed in the machine, as you can see here. This is, for example, a plan for the angiography of the left coronary artery. So you have different trajectories for these dual axis rotations, and this gives you the chance to have your rotational angiography which covers all these regions where you have the minimal foreshortening for calculation of that what you're doing. And it is an example for the application in the congenital heart disease. You see that is a rotation from the RAO caudal to the LAO cranial, and it is the example what you can get here. This is the example I showed you in the first slides, an adult patient with aneurysm formation, and after a covered stent graft implantation, which you can see here, you can easily check the result afterwards with the same projection in any way. But the future is not really focused with the advanced rotational angiography, because this enlarges and prolongs the acquisition time of, to roughly 5 seconds, and means that you have to plan your dye injection for another half a second or 1 second, which means 7 seconds dye diluted dye injection, and that gives you an amount of contrast medium load, which is probably significant for the patient. So what you can do is you can fuse of those imaging projections you already achieved with the MRI or the CT data, which already have the content of three-dimensional data, and you can use this as an overlay or an additional spatial reconstruction model for that what you achieve as an additional information with the fluoroscopy. So this is in somehow a commercial product for the CT information, which is coming from Siemens and Philips, and I think from GE and Toshiba as well. But for the MRI overlay and for the echo overlay, for the echo navigator, it's only commercially available now from the Philips company. So here you see how it works. The pre-processing is very important. These, for example, are MRI data from a 3D whole heart recording, and you have to implement these data into your angiography system. Afterwards, you have to do the segmentation, and there is some software which gives you the opportunity to give colors to detect that what you want to see. Red one, for example, is the aorta, the green one is the pulmonary artery, and blue is the right ventricle, and you can see it here. And you can rotate everything what you want to see and want to calculate on. So then after the pre-processing and importing the data into your machine, you can do an anatomic selection, whether you want to see LV and AO, whether you want to see LV, AO, or right atrium and pulmonary artery, or whether you want to see everything. Which is very easy for you. It's a colorful picture, which is somehow an art, and you can then choose what you want to see. Here in green, the pulmonary artery, in blue, the right ventricle, and roughly not a detail, but roughly information about the course of the left coronary artery here, just to plan a implantation of the stenting of the pulmonary artery prior to the PPVI. Here you can see that is your information in a three-dimensional reconstruction, and you can put this for an overlay technique with the contour of the pulmonary arteries and the RVOT and the right ventricle, and you can see in this overlay projection the orientation of your stent, the placement of your stent with regard to the three-dimensional information you prior acquired. If you have these pre-processed data in your machine, you can also mimic a implantation of different devices. Here we just started to look how it looks like if we would put in a pre-standing at that region where we have an approximation to the left coronary artery, and you can play with that and see whether if you implant a 12 millimeter, 18 millimeter, or 22 millimeter diameter, whether this will impair the origin and the mouthing of the left coronary artery in any way, and you can play with different implantations of valves, like an Edwards valve or a Melody valve implantation. At the very end, this is how you can do it. You can easily manage the opacification of the three-dimensional overlay and the fluoroscopy. You can focus a bit more on the fluoroscopy or a bit more on that three-dimensional model as you want. You can achieve it from the angio machine where you're working with. And here you see how we do it. This is inflation of a PA stent with regard to the anatomy. And to minimize the turbulences which are going to be created in the MRI model with a previously implanted stent, in this situation we just cut off the left pulmonary artery because that is not necessary for that information and placement what you need in this situation. So this is the same patient after implantation, the Melody, and you could see that we had not only the pre-implanted EV3 Max LD stent, but also the Melody stent afterwards, and so it was very helpful for this situation. So with regard, I like to the three-dimensional modeling and the rotational angiography, I like to conclude in very complex spatial anatomic conditions, it may help to get you an information about the three-dimensional impression of the vessels. It, in addition, helps to find you the optimal view to the target lesions to plan your procedures. And it may help, and if not, it helps to reduce the measurement errors due to foreshortened projections during the stent implantation. That means especially in length of the lesion you have to deal with. And it for sure may reduce X-ray exposure, not only of the patient, but also of the investigator. With regard to the road mapping, I like to conclude that the MRI and the fluoroscopy fusion, the so-called mapping, is very useful. It gives you additional information on anatomy, on complexity of the lesion you're going to deal with. It improves the orientation and the pre-planning of the procedure, and the mapping might be very beneficial in complex anatomy and intervention. Landmarking is additional information, especially with regard to any safety aspects. I think to summarize everything, this dedicated congenital rotational acquisition does not necessarily replace the biplane angiography, but facilitates better optimal views of the anatomy of interest with just one acquisition instead of having two or three in any way. So, with the potential of the image fusion, what I mentioned in the last part of my talk, the debate of the dual axis scan, this advanced rotational angiography, or the 180 degrees rotational angiogram has come to an end. So this is the future, that you have all the three-dimensional spatial information for you as a pre-planning, imaged fused tool to give you on-site the possibility to have every information you need for the procedure. Thank you very much for your attention.